Good day, everyone. We are very happy to warmly welcome you to this webinar. My name is Dr. Viviana Munoz-Teles, and I head the program on antimicrobial resistance at the South Center. The South Center is an intergovernmental think tank of developing countries with 55 member states across Asia, Africa, Latin America, and the Caribbean, and we are based in Geneva, Switzerland. Antimicrobial resistance is a significant global challenge. It was estimated to have caused about 4.95 million deaths just in 2019, and deaths are set to increase by 70% by 2050 to close to 40 million deaths. This startling evidence points to the importance of using antibiotics with care and to practically implement stewardship so that we can prevent and treat infections effectively, alongside many other interventions that are necessary within a One Health approach. The South Center is hosting this focused webinar to present a new guide framework for antibiotic prescribing that builds upon existing guidance, including the WHO AWARE classification and guidelines for antibiotic prescription. The guide is a practical tool, a 5-step framework for antibiotic prescribing designed to translate into practical steps for prescribers, antimicrobial stewardship teams, and policymakers across diverse settings, taking into account considerations of different country contexts and facility contexts. You can find the guide framework now published on the South Center website, and you will also find there this recording of the webinar and as well as the slides that will be presented today. I am very happy that we can have with us today the framework author, Dr. Rasha Abdelsalam Elshenawy. Dr. Elshenawy is a distinguished Egyptian clinical pharmacist with over 20 years in pharmaceutical practice. As director of the Antimicrobial Stewardship School at FADIC in the United Kingdom and as AMR consultant with the South Center, Dr. Rasha also serves as a senior lecturer and supervisor at the University of Hertfordshire in the UK. The purpose of this webinar is to launch the guide framework for antibiotic prescribing and to receive from all of you your feedback and discuss recommendations to promote the usability of the guide framework, particularly in the context of developing countries. The intended audience of the webinar is varied from prescribers, pharmacists, nurses, AMS committees, hospital managers, Ministry of Health officials, educators, and digital health teams, but as well as more broadly, policymakers, academics, and students. This webinar will have 2 parts. First, a presentation by Dr. Elshenawy, followed by a question and answers. Feel free to post your questions in the Q&A function you will find at the bottom of your screen. Thank you very much, and I hand over to Dr. Elshenawy.
Thank you very much, Dr. Vivian, for introducing me. I'm delighted to be with you today to introduce this guide framework as an evidence-based prescribing tool to optimize antibiotic use and antibiotic prescribing and maintain effective antimicrobial stewardship implementation from the practitioner or healthcare workforce to the organizational level. I'm delighted to be with you today to launch this guide framework after extensive work of research and evidence-based literature, and from all my expertise over 23 years of experience and in antimicrobial stewardship research and publication. I'm delighted to launch this guide framework as an evidence-based 5-step antimicrobial stewardship for safer, smarter antibiotic decisions. First of all, I would like to speak about the antimicrobial resistance as a global health threat. Antimicrobial resistance is found to be one of the most 10 global health threats worldwide, and it causes over than 1 million deaths every year in all healthcare settings and also in low resources countries. After the recent report from the WHO, just recently the GLASS report, that 1 in 6 bacterial infection is now antibiotic resistant. For this reason, it's important to understand how to use antibiotic effectively in order to reserve the broad spectrum or the powerful antibiotic to the patient who really need it. We need to decrease the risk of antimicrobial resistance, as common infection now is become untreatable, and antimicrobial resistance become one of the silent pandemic spreading worldwide. We see COVID-19 pandemic rising the number of mortality, but also we have antimicrobial resistance, which significantly increase the number of deaths. Now moving to the next slide to have common definition about antimicrobial stewardship. What is antimicrobial stewardship? Antimicrobial stewardship is a coordinated set of strategies aimed to improve the antibiotic use, antibiotic prescribing, and enhance patient outcome. Antibiotic stewardship aiming to maintain the rational use of antibiotic in order to decrease the antimicrobial resistance. Antibiotic stewardship is aim also to ensure sustainable resilience, antibiotic prescribing, and the responsible use of antibiotics in all healthcare settings. From here we start, and also I start with this patient in ICU, and we could not find any antibiotic to treat this patient. Unfortunately, we have many of these patients in all our healthcare settings with all our families and friends. We have, I'm sure we have or met a situation we find the patient is resistant to all available antibiotic, and unfortunately there is no antibiotic reserved or protected to treat this patient. And unfortunately, this patient died. For this reason, without stewardship, without mindful use of antibiotics fail and patient die. And for this reason also, antibiotic stewardship is important to preserve antibiotics for those who need them most. The most important lesson from this story that antibiotics are precious, and without stewardship, we lose them. We need all to know and learn how to implement antibiotic stewardship into practice as healthcare professionals, as an academics, as a researcher, as a policymaker, on organizational approach on national level. And I'm sure with this guide framework, which we will discuss today, we will find antibiotic stewardship practice is an easy, simple, smart, resilient, could be integrated in any healthcare setting and with any healthcare professional. Why antibiotic stewardship is essential as we mentioned earlier that 4.9 million deaths linked to the antimicrobial resistance, and we need to maintain appropriate antibiotic use, and we need also to ensure that antimicrobial stewardship is applied or practiced or implemented in more efficacious way and in more effective way in healthcare setting. For this reason, antimicrobial stewardship is essential for global health security. Why this new guide framework? This new guide framework is implemented after extensive work, more than many of work, to release this framework as a tool to integrate the most available antimicrobial guidelines, such as the WHO aware guidelines and the WHO aware classification and the UK HSA Start Smart and Focus, and also other global guidelines, in order to provide a simple way and a straightforward way and easily adaptive way to healthcare professionals to help them to optimize antibiotic use and maintain judicious use of antibiotic. We hope also this guide to be implemented also with low and limited resource setting, and could be integrated in policy in order to be implemented on the global level. This guide framework includes 5 important steps. The first one is to gather evidence, and we will discuss each step in more details in the further slides. The second one is urgency and source, and the third one is identify choice. The fourth is define duration, and E, evaluate and review. This guide framework bridge policy and evidence-based practice to equitable antimicrobial stewardship implementation in any healthcare setting as a tool, as a guidance, as a support, decision support tool to help all practitioners, all health professionals to maintain like systematic or structural approach when they prescribing antibiotic or dealing with any infectious disease patient. This guide framework in more overview, including the 5 steps, which is started by gathering information and evidence about the infection assessment, the patient risk, and answer one of the most important question. Does the patient has any signs or symptoms of bacterial infection? This one of the most important question we need to ask when see any case of patient has infection. Does the patient has signs and symptoms of infection? This is the first important question, which is gather evidence and access. The second one is urgency and source. And we know, I hope, I'm sure all listen about sepsis and how sepsis need act fast or urgent response from the health professionals to prescribe the broad spectrum antibiotic within 1 hour of patient admission. So in this step, we need to act fast, find the source of infection and focus for this source. This is one of the most important steps, which is urgency. The third step, which is identify choice. After we gather the evidence about the infection and identify if the patient case is urgent or not, we need to identify the choices. Learn how to select the right antibiotic to maintain the antibiotic safety. And does the choice follow the local guideline or not? And we need in this step to consider both the WHO aware classification and guidelines for antimicrobial stewardship and the UK HSA Start Smart Then Focus. After identifying the source of infection, how this infection is urgent or not, we need to follow the local guideline with regard to the aware classification and the start smart and focus. Then the fourth step, which is very, very important, which is duration planning. We need to define duration from day one. As per local guideline, and document this duration in the medical record of the patient or any prescription of the patient, following the local guideline and national guideline. And finally, E, which is evaluate and review. We need to review evaluate the progress of the patient. If the patient is clinically stable, what further action needed. All of these in order to take the evidence-based decision if the patient should continue or switch, as I will discuss further in the later slides. So this framework is making like overview for all the guide framework. For this reason, we name it guide. G for gather, U for urgency, I for identify, D for duration, and then evaluate. Let's go after this to step by step of the evidence of the guide, evidence-based prescribing, and understand what is required or what answers need to be asked in each step in order to fulfill the criteria for each step in guide framework. The first step is gather, which is gather evidence. Like I mentioned, we need to assess the infection, the patient risk before prescribing, confirm if this bacterial infection or viral infection, see if there is any lab results or history of lab results. This will strengthen diagnostic antimicrobial stewardship. And we can implement this part into the policy to invest in testing capacity and workforce training to understand how to evaluate the patient, how to gather information about the patient history. In this step of guide, we need to consider 5 important elements to answer the question of does the patient has any signs or symptoms of bacterial infection to start antibiotic or not. The first one is check for infection. Any laboratory examination, any history of the patient, if the patient have immunocompromised or have any other disease that affecting this, or prior admission to the hospital, or prior taking antibiotic or not. and investigate if needed by seeing if there is any culture result, if there is any lab result, if there is any organ dysfunction. This is very important. And one of the most important, which is stop antibiotic. If you suspect the patient, if you could not find any source of infection, if the patient's signs and symptoms go with viral infection, if the patient is clinically stable, and you need to document all of this in the medical record of the patient. Or proceed antibiotic if you find strong signs and symptoms of on the patient related to the bacterial infection. Start antibiotic immediately and also document this clearly in the patient records. This is the first step, which is important to be systematically and structurally think about the patient, if the patient has infection or not, which is gather evidence of infection and patient risk. The second step, as we mentioned, which is urgency and source, and this is one of the most critical steps of the guide framework, to identify the source of infection. In all of my expertise, more than 20 years, and going clinical rounds with the patient and leading stewardship implementation in hospitals, and here after this with the literature and academic and research, the most important, and when teaching students post or undergraduate, the most question of the most step from the clinical perspective is to identify the infection source. As you know, the source of infection, you could be able to go for the local guideline. You could be able to understand systematically what is the possible organism, what is the possible infection, and then could be able to prescribe antibiotic effectively in this way. And then, if you suspect patient has sepsis, sure, it's important to start the antibiotic within 1 hour of patient. And for stable patient need more investigation, you need to go with the patient according to the clinical condition. And this step is very important to be integrated in the policy to improve the sepsis early recognition and prevent the mortality and death from sepsis. So in this urgency step, we need to act smart and fast, find the source of infection and focus on this source in order to identify the antibiotic according to the local guideline. So to answer this question, is the patient has sepsis or severe infection, we need to consider 4 important elements. Identifying the source, if the source from the respiratory, from the urinary, from the skin, intra-abdominal, bloodstream, CNS, what is the source? This will help to guide the antibiotic choice. The second part is to consider the antibiotic prescribing according to this situation. If need immediate interventions like sepsis or critical or severe patient, we need to start the antibiotic within 1 hour and continue the sepsis maneuver like fluids, the source control, sending culture before start antibiotic. This is very important. Or guided antibiotic patient is not severe, so I need to go to the narrow spectrum or narrow effective antibiotic and take culture before starting antibiotic and consider reviewing. Or targeted antibiotic, and this is very easy. If we find investigation and the investigation reveal a specific antibiotic, so in this reason we can start after culture result or after investigation to the narrow spectrum antibiotic and then document. In these 3 steps, the most important part is to identify the source of infection. This is in step number 2. With regard to step number 3, we identify the source, we gather the history of the patient and the evidence, go to the we need to use our tools, the WHO aware guideline, the UKHSA, start smarter than focused. We need to start antibiotic as per the local guideline. And in this case, we need to remember the the WHO aware classification to access. If we can start the antibiotic or the first line antibiotic from the access antibiotics, that would be very great to reserve the watch or reserve to the patient who has severe conditions. And important to apply the 8Ds or 5Ds of antibiotic safety, right dose, right duration, right diagnosis, right route to ensure that antibiotics are used in safe way. And this step is important in policy implication to update the drug formularies and strengthen AMR surveillance in order to strengthen the decision with regard to the antibiotic stewardship practices. So for this identify, we need to select the right antibiotic. After we know, gathering information, assess how the patient is urgent or not, and identify the source of infection. Then at the right antibiotic, we need to select right according to the source and local guideline, and using the global guideline of the WHO or national from the UK. So to answer this question, does the choice follow the local guideline and the WHO aware criteria or aware classification? We need to identify choices using the local guidelines and consider other safety parameters, the allergic checks, if the patient has any other conditions, and consider the WHO aware classification from the axis, which is first choice or narrow-spectrum antibiotic, or watch, which is justify or need to watch these antibiotic, coamoxiclav, piperacillin, tazobactam, meropenem, ciprofloxacin, or reserve, which is the last reserved antibiotic, or protected, I call it protected antibiotic for the patient with severe condition. And apply of 5 Ds, 8 Ds of antibiotic safety, and also focus on consider the duration, the de-escalation, and then document all this in the patient record in order to facilitate the other or the next upcoming steps after this. So now to step 4 and 5, which is define and evaluate. To define or set duration for the patient from the day one, and then after this reviewing the antibiotic, as we will see in the after this in the next upcoming slides, how to evaluate the antibiotic use and take the proper decision using the national guideline from the UKHSA, which is CARES. We will see it in the next upcoming slides to determine the right decision for antibiotic prescribing. And this step is very important in policy implication with regard to the mandate documentation in the electric health record of the patient and the audit activity in order to ensure antibiotic is okay prescribed, but we need to ensure that after this patient is taking antibiotic as regard with the clinical progress and the patient clinical condition. So for step number 4, which is duration planning, what the most important question need to be answered: what is the antibiotic duration according to the local guideline, considering the typical duration, as I'm sure each healthcare setting has local guideline, and we have also the national guideline and the WHO aware guideline, all of these documenting the duration or typical duration of using antibiotic with different sources. If from the urinary tract infection, how is the optimum antibiotic to use, duration for the pneumonia, for the skin and soft tissue, for surgical prophylaxis. So make sure to follow the local guideline. And if you go with this systematic approach, you can follow the guideline easily. And then document. The documentation is one of the most important steps. I put it here in guide framework because with this documentation, we maintain safe handover and the transition of the patient in different clinical setting. And the stop criteria, make sure when to stop the antibiotic, if the patient symptoms improving, if the biomarker is normaling, patient febrile, no active infection, and review. There is a schedule for reviewing the antibiotic use in order to ensure the antibiotic is used in effective way. And stop if the patient no has any clinical justification of infection. This is step number 4. Let's go for step number 5, which is evaluate, progress, and review. This is most important step, and we use in this framework the national guideline from the UKHSA, which is a start smart then focus. We will now go to the then focus criteria. We need to answer this question. Has a structured review, start smart then focus, have done or been done or conducted or not? This include very important steps, which is not only one review, it needs systematic review or different review points. Initial one from 48 to 72 hours. This important review to check the fever, the vital signs, if there is any issues with the patient. This mainly after admission or after the first taking patient from 48 to 72 hours. Then reassess in day 5 or 7 to reassess if the patient if we need to stop the antibiotic, if the patient could be have viral infection, so need to stop antibiotic, no need for this. If the patient could be switched to other antibiotic or de-escalate, go to the narrow spectrum antibiotic, confirm stability. Then extended after day 7 or the 7th day to continue with justification. This is very important review. If the patient now the patient taking antibiotic for 7 days, do we need to stop the antibiotic? What is the justification? And need to document this in the patient record. This is very important, and each time point the review is different. From the admission to suitability, if the patient has viral infection or bacterial, if going with local guideline or not, then reassess after 5 or 7 days, after 5 days, to see if you can switch to other antibiotic or stop or continue, or asking for ID consultation or microbiology consultation, or extend if the patient has severe infection and you consider extending or switching to other antibiotic, or discharge or discontinue. All of these decisions differ from the patient according to the clinical justification of the patient. So using this start national from the start smart focus, the cares outline, consider ceasing or stop antibiotic, amend or change antibiotic, refer to microbiology or ID consultant, extend, you can continue, or switch from IV to oral route. So this is very important, daily review and documentation to maintain that you are using antibiotic properly. Unfortunately, we see a lot of issues. Patient could be continue on antibiotic without further review. The review process is not complete, and this one is most important one to maintain the quality assurance of antibiotic prescribing and maintain antibiotic stewardship implementation in an effective way to preserve antibiotic. Stop antibiotic if the patient could not need, or consider using narrow spectrum antibiotic. This is the end of the guide framework. Here is the guide framework as a whole. I put all the steps all together in order to be like a decision support system to help the health professionals on daily setting. It's really important. Your decision today, preserve tomorrow antibiotic and maintain effective antibiotic. The main aim of this guide is to ensure that antibiotic is used properly, the simple one or the narrow spectrum one, used for the mild cases, and reserve the most powerful antibiotic to patient with severe condition who really need this antibiotic in a proper time. For the monitoring and the impact, we have different monitoring parameters, even see how review could be completed, the indication for review, the reduction of the watch and reserve use, the guide incorporation into stewardship audit, and how to integrate this guide framework into the electronic health records and dashboard, and how to use the GLASS AMR surveillance to support this guide framework. This need to be used in a smart way in order to use the WHO data, which is very precious, to identify the data gap, not data gap, identify the most targeted intervention according to each country, and use this guide framework to support antibiotic prescribing and stewardship based on the data from the AMR surveillance plus report. And finally, we need to call to action to adopt this guide across national and institutional antimicrobial stewardship programs, empower prescribers, not only prescribers, all healthcare professionals, all workforce, all frontline staff, and the antimicrobial stewardship teams through training them how to use this, how to use with different clinical situations, case scenarios, to understand how to use it effectively, to build leadership and the digital infrastructure for sustain. The most important issue is sustainability. As we see in COVID-19 or any problem or any emergency that disrupted the healthcare setting, we need to maintain the sustainability and the resilience of this guide framework and turn this evidence into action to preserve antibiotics for the future. This is the end of my presentation, and thank you very much for being with me today. I hope to answer all of the questions and facilitate the implementation of this guide framework. Thank you very much for listening, and I hope to be this guide implementation to be implemented on the prescriber or healthcare professionals level, in healthcare setting, and also in national and global level. Thank you.
Thank you so much, Dr. Elshenawy, for taking us through what is a very comprehensive guide, but you were very ably showing us through the key elements and key steps of the guide in quite a limited time. So thank you very much for that. As we have mentioned before, the guide has now been published. And this is an invitation both for feedback on the guide when you are able to read through it more in detail, but also an invitation for use and to think about how can we further disseminate this tool, in particular in developing countries where we know there is substantial need for guidance. And one of the elements that I really appreciated reading the guide is how it also helps to guide, clinical decision making, which is, partly informed by observing the patient and with aligned to the antibiotic guidelines that there might be in the national context. Knowing that in the situation of developing countries, many times we have additional problems of, for example, limited access to antibiotics, so requires, thinking in having an idea of what could be then the possible antibiotics to be used and making sure that these essential antibiotics are adequately available. And at the same time, for example, with the limited laboratory capacity, that we cannot depend every time on the laboratory confirmation for diagnostic, but also, the importance of that clinical observation that is being made. So all the challenges in developing country context compounded is a very clear reasoning why we need additional tools, such as the one that Dr. Elshenawy has now developed. And what we are asking for you now is just to help complement with your experience in particular at the domestic level. How can we disseminate more the use, and if there's any other ideas you think that should be added on to make the guide as user-friendly as possible. So with that, I would just again point to that the South Center website will have all these resources. There will also be a survey that is being made available so that you can provide some inputs with regards to the particular guide framework once you are able to do so. And this will also be added on here on the chat so that you're able to do that. All the documents, the presentation will be on the South Center website. So you'll find in the last slide now of this presentation, the website for you to see. Right now it is in the head page, but you can also then find through the antimicrobial resistance documents of the South Center, you will find this guide. And here you have the landing page where you receive where's the guide framework. You will also find here the presentation after today posted, and as well as the survey link for you to be able to provide a feedback, which is here on this slide. You find on the right bottom side, that is the reference for the guide. So with that, we will now move on to the Q&A section of our webinar. Just to note, for those who have made a question in the chat, it would be preferable if you can insert that in the Q&A, as then we can have that all together in one side. And as this recording will also be available, you will be able to see your questions that are answered reflected as well as part of the recording. So if I could just ask those who have made some questions in the chat, if you're able to reintroduce those in the Q&A function, that would be wonderful to facilitate the answers. So Dr. Elshenawy, back to you for answering some questions. I hope you've had in this short time the ability to read through some. We have about 30 minutes, so hopefully we are able to answer all the questions that are coming through. Thank you very much for your participation, because this is really what we're looking forward to have some of this interaction with you in this webinar.
Thank
So,
you very much, Dr. Viviane, for your input, which is very important. And I'm delighted also to share this link guide for in the presentation, the link for the guide framework, which is very important to all of you to go and read. It provides further classification, further explanation of all what we discussed today. With regard to the questions I can find in front of my screen now, the first question is in developing countries like Pakistan, people habit is self-medication, which is not allowed and cause antimicrobial resistance, but how we can reduce this to help different stakeholders. I know in some in many countries, antibiotic is self-medicated and prescribed, taken without prescription. I understand this. However, I believe in the role of policymaker and the awareness to promote this issue. We try to make this guide framework to support all healthcare professionals and raise awareness. And believe me, based on real experience, people need to be educated. So, and this with this WHO awareness campaign and all of these resources, you can use these resources to raise the awareness of the people. And once the people understand that antibiotics could not be shared with others, need to be antibiotic as prescribed, don't take antibiotic without any infection, people become aware and could be able to understand this. This is very important. With regard to the second question, this is a quite thank you very much. How can this integrate it into primary health facilities in low middle income countries and making it more relatable, considering some of them still need strengthen. Yes, I understand. We could not find a perfect, because this is not a perfect health setting. Having everything is perfect. I'm sure system need to be improved all of the time, and if there is no diagnostic stewardship or have not limit not strength diagnostic stewardship, using this framework will help at least to understand and could be able to go with a stepwise or structured approach. If the patient don't have any signs or symptoms of bacterial infection and you can have no symptoms, in this moment we need to not start antibiotic, not start with broad spectrum antibiotic. For example, if the patient has have symptoms in like community acquired pneumonia, and you could not find curb score or any risk assessment tools to guide that the patient is a good candidate to use antibiotic, then in this moment you keep the patient under consideration. Or if you find the patient in mild stage, you consider start amoxicillin or access or narrow spectrum antibiotic, and then after this you can see the patient prognosis. With regard to the primary health facilities, I'm sure this guide framework will be a great addition, because antibiotic, this is like a decision support tool for all prescriber, for all health professionals. So using this tool will help you to understand. You can implement this tool using the local guideline from primary care facilities, and also with the patient you see every day on daily basis. Like if the patient has sign or symptoms of infection, what is the local guideline according to the source of infection, and could be able to take the right decision. So I'm sure this tool will help healthcare professionals in secondary and primary and tertiary care setting. I see another question: how to deal with microbial resistance for the patient using this medication without prescription order? This is a tricky question. I know this. Sometimes the patient takes this medication without prescription order. However, now we are working to raise the awareness of all health professionals in low and limited resource setting, and also in developing countries, and also in the developed countries. I know this is a very big problem. So I think with this bacterial or microbial resistant, raising awareness and also the education and the training. So if I raise the awareness of the public or the patient that antibiotic is not used without prescription, and when using antibiotic, you need to ask and consider and ask the healthcare professionals, and also educate and train the healthcare professionals in an effective way, that this will be a very complementary effect in the developing countries and or in any setting. The second question, if possible, you can share with us. Yes, I think this will be slides will be uploaded on the South Center websites. You can download from South Center after finishing our webinar. With regard to the questions.
Uh,
Uh,
Giovanni, there was one in the chat. You have answered all the ones prior, but there's a new one coming up. But one in the chat that you might not have seen is a question of, can this guide substitute the national guides a
no,
country has or incorporate it?
no, no. This guide is is complementary to all these national guidance and also to the global setting. I'm not saying we need to be complementary. We to use all guidelines. And as a healthcare professionals, you have to follow the local guideline, which is very important because the local guideline take in consideration one of the most important issue, which is antibiogram or the cumulative report of antimicrobial resistance. So the local guideline is the first to consider the national guideline. After this, to see the national pattern and use the national guideline. And this tool, this guide framework, on the other hand, will help you to follow the national and the global guideline because this WIS tool, you know at which stage, if you, for example, suspect urinary tract infection, so you will go to the local guideline and the national guideline and see which antibiotic is recommended to prescribe and then follow this guide. So I think this guide framework is complementary. It will help you to take into your consideration the national, the local guideline, the national and the global one. Um, I think
I think we have covered all the questions.
yes. Uh, yes, I think in order to achieve another, I have question, achieve antimicrobial stewardship, there is the need to finance. I understand. And the capacity the frontliner in its use. I understand the issue of the finance. However, I believe also in the most important rule. I know I could not say that the finance has no rule. However, I can say that the healthcare professionals be well trained, well educated, will help them to use this finance and maintain resource allocation and maintain the capacity of antimicrobial stewardship implementation. So I know and I agree with you, and I understand the finance has important role, and but also I understand that if the presence of healthcare professionals, well educated, well trained, could be able to use this guide framework effectively, will help in antimicrobial stewardship implementation and the practice. Uh,
There's a new question coming in.
uh,
Sub-Saharan Africa, there are so many substandard drugs being supplied that are exacerbating antimicrobial resistance. How can we deal with this with regards to the relationship with antimicrobial steward?
the first part about the, I know there's in not all countries has system to prescribe antibiotic, but as I mentioned, I believe in the role of the training and the education, which help the healthcare workforce to be well educated. I'm from developing countries and I understand all what you say. So if you speak with the patient, if you explain to the patient that this antibiotic could not be used, if you are in a position in practicing or pharmacist, nurses, doctor, and educate the patient that antibiotic should not be used in this case because this case is viral infection, could not be used too much antibiotic, not taking too much antibiotic will help you to cure early. Believe me, patient will understand and will help you and will be with you. So we need awareness from two levels, as I mentioned, from the public level and from also the healthcare professionals to be well educated to be able to counsel and educate the patient and guide the patient regarding the proper antibiotic according to the clinical situation. I have a question also about the sensitivity test. Yes, I agree with you about the sensitivity test and the culture result and the use of the lab and the investigation is very important and very important to consideration. However, this guide framework is mainly about the evidence-based antibiotic prescribing. We need to consider all of these and the result of sensitivity test or culture test or lab results. It is in the step of the gather information and identifying the source and in the review and document review the duration after this. So each one of them present in each step of the guide framework according to the suitability and the use. But sure, the cultural result or investigation or any test is very helpful to guide the decision whether to continue, whether to stop antibiotic according to the clinical situation of the patient. Vivian, I could not be able to put the link of the survey. If you could be able to put it on the chat, I would be very grateful to you. I have a question also. Uh, Thank you very much, Abu Bakr. Thank you very much for being with us from Nigeria. Thank you very much. I used to teach many of the students with me from Nigeria, so thank you very, very much. Very nice to be with us today. Continue to read. Yes, yes, to awareness of IMR. How can global policymaker come together to enforce a stricter regulation against the sale of antibiotics without prescription for both humans and animals? From my side, I will answer my side, and I will also ask Vivian to join me and answer this from the policy maker. As I also always say, we are trying to make this into the policy, and we write the policy to help the policymaker to take proper decision regarding this selling antibiotic without prescribing or without prescription. However, for the animal and for the human use, I agree with you. However, also from my perspective, we need to make like a complementary action. We need to raise this recommendation and raise this framework for the policy maker to help them to take the proper decision. And also, on the other hand, we need to educate our resources, our manpower, to help them to be able to, believe me, this is very important. The presence of healthcare professional could be able to understand, to implement the antibiotic stewardship, and this tool could be used very, very easily with any resource countries or of any of developing countries. This will be able to provide like decision support tool to the health professional to help them to take the aware or the proper decision. And finally, raising the awareness of public of not taking antibiotic for viral, not sharing the antibiotic with each other, taking antibiotic as prescribed. This is very important element to complement each other from the policy to practice consideration. Vivian, if you would like to add anything.
Yes, certainly. I mean, I think what we have in both aspects is that we do certainly need to promote that the use of antibiotics is guided by the guidelines that are provided domestically and with best international practice for. Ideally, it should be under prescriptions, but we really need to look at what's the particular context. For example, in settings where we have weak healthcare systems, we want to ensure that we can balance appropriately the enforcement of regulations of having antibiotics only under prescription, but also ensuring that we recognize how access to healthcare is happening. So, for example, the important role of pharmacists and community workers in some developing country settings, where what we need to do is really first focus on the training and education, as has been mentioned. And of course, regulations need to go hand in hand, but we don't want to, certainly just create a number of regulations where there can be side effects, such as, for example, fostering more of a black market for antibiotics, for example, because we haven't addressed the key issue of why there's this misuse and overuse of antibiotics and why people are self-prescribing instead of going to get the adequate guidance. And this happens in the animal side as well. So when we have a lack of veterinarians to go to when, the treatment of an animal can be a life or death for a whole family that depends from the livelihood of these animals, then we might be misusing antibiotics either for preventive purposes when we haven't determined that there was a need for that antibiotic to treat the animal infection, or also then to misuse such as for growth promotion when that shouldn't be the case. So we should have first education training to ensure that there is proper understanding of when should antibiotics be used or not. In animals, for example, only certain situations for prophylaxis, definitely not for group or herds if we have not identified that's necessary. Use alternatives such as vaccinations where possible, or alternatives to antibiotics such as probiotics and others, and as well as ensuring that sales are better controlled. And that is again an issue about what is the access situation. So if you live in a very far rural area and veterinarians are very far away, how do we create an in-between sort of veterinary support that mimics what is a trained pharmacist that can support better use of antibiotics in animals when it's the necessary situation, but not just for actions, for example, in growth promotion. So I think while this guide does not address the interaction specifically with animal health, we can draw upon many of the lessons in terms of the kind of actions and the kind of prudence that should be applied by veterinarians, as well as what's being suggested here for the healthcare workers, either frontline or whether they're clinicians in different facilities. Just related to that, I think again there was a question with regards to how could this framework account for veterinary aspects of prescription. So I think this is what we were talking about now. And it is an interesting point to see if there is interest, if you have seen from your experience in these areas that there's a need for better guidance, that would be useful. And we at South Center, we've been working also on this for quite some time to see what else could be useful to develop, because we know there's many tools from WOA as well from FAO on this area. But if you identify that some more user-friendly tools could incorporate that guidance, but in a more user-friendly way, such as with this guide for the human health, then we'd be happy to also work more in that area.
Thank you very much, Dr. Vivian, for your answer. Very, very comprehensive answer to this issue. With regard to the second question, the healthcare workers can be trained on how to do visual inspection at the point of receiving the drugs, as well as proper supplier pre-qualification. This indeed a challenge, specifically in sub-Saharan Africa and worse in rural setting. I totally agree with you. I see, I can see many of its challenging situations, but I believe in the rule of and I agree with you about the audit, which is very, very important. But using this audit effectively to build or to make quality improvement projects to continue improving antibiotic prescribing is very important. I know there is a lot of challenges with rural area and limited resource settings. However, the presence of this tool or and also creating from visual, because I have experience with this issue, audit tool, and you can share this audit review feedback with help with stakeholders, because I see other question in the chat was about the stakeholders. Stakeholders need to be aware by the audit results, and this audit results to maintain continuous improvement and as a key performance indicator. For example, if is any department has more infection, if have some sort of patients, or what is the most clinical condition we have, what is the most antibiotic is misused, all of this. So it's not sufficient to take the training and education alone. We need to integrate this training and education into your clinical practice, and I believe audit is very important. Additionally, audit will help to implement the review schedule. As I mentioned, in the final step of the guide framework is to make like a schedule for review after 2 days, after 3, after 5 days, after 7 days. But this is very important into your practice, and also share all of this feedback with the stakeholders. And I was in one of my hospitals, I used to work with them. The healthcare professionals, or many of them mentioned that the healthcare professional themselves need to be aware on yearly basis or monthly basis about the update of the audit. This will help to raise awareness and to keep improvement. I can see another question. I undergo training on AMR. What step should I follow to reach a stakeholder? The most important step for the stakeholder is how to visualize the outcome of your work and help them to or guide them to take proper decisions. So one of the most important issues, like I mentioned in the previous question, that's good that you take the MR training, continue and finish it. Then after this, take training about the antimicrobial stewardship in particular, to understand how to use this guide framework, national and the global policy of antibiotic stewardship and the guidelines, and then start practicing in your place. If you are pharmacist, if you are nurse, if you are doctor, if you are in infection prevention and control, and after to practice this to the type of patient in department or in hospital, in ward, for example, intensive care, emergency department, share this result with your colleague to raise awareness, to improve this. This is my work, this is what I'm done. So you need to raise with them the feedback of your work. How many cases appropriate antibiotic prescribing, how many cases not prescribing, what is the trend, what is the pattern, and also with the stakeholders. This is very important for them from 2 points to see the significance of your practice and to take proper decision with regard to the further improvement in your practice. Believe me, this is very important, and based on my experience will help you to improve antibiotic stewardship and antibiotic prescribing and have significant impact on the AMR. And when I see hospitals or healthcare facilities applying this issue and see the final yearly or annual report of antimicrobial resistance, I find this significantly decreased. So this is very important to involve stakeholders into your work. I can see the last question into the chat. Can you imagine the staff become resistant? I agree with amoxicillin IC while remaining sensitive to sulfa in sample culture, cultured from a camel, and it was taken from the blood. This mean that she camel was injected with yes, I agree with you. And also I agree with you in one important issue regarding the bacteria resistant, because bacteria resistant is due to the mutation of the bacteria. And I used, when I'm teaching the antimicrobial stewardship, to give important session about the bacteria to understand the behavior of bacteria. And this is very important to you now to know that this resistance, so we need to not taking over beta lactam. And you can see in the history, because I'm not sure about the history, how long she take previously the amoxicillin to be resistant to this amoxicillin, or could be infected, not taking enough, could be infected from other camel or from other one has already the significant one. I remember when Alexander Fleming take the Nobel Prize, when he mentioned about this issue specifically, when antibiotic is taken as misused or not rationally used, antibiotic, the bacteria become resistant, and the bacteria this resistant bacteria could be infect other patient, and they continue. So this is very important to consider. PhD and in AMR. This is very good. I did it before. I did it before, but this is very important. This is an academic question, but I think you need to access the proper university and see the proper supervisor to help you with this. And believe me, it will be very important to add contribution. You are a vet. This is very great. You can start, because there is a great need for this, for to evidence-based work in antimicrobial resistance and stewardship. I hope for you to find the proper faculty and the proper supervisor. We have 3 minutes. We have 3 minutes.
I think, yes, we can be closing. There's one question, perhaps is great to bring us towards our closing, which is Philip Wongo asked, how can I reach stakeholders to preach this guide? So in terms of the follow-up, what can we do to ensure that we have adequate dissemination? And with that, I think we can start our closure. I will be trying to put the chat here for the survey. If not, we'll point you again to
yeah.
the South Center website.
Yeah. I think I answered already the question with regard to the stakeholders. The most important part, I think this is the end of my questions. The most important part with the stakeholder to involve them is to show your work, present your work in a easily visible tool to help them or guide them to take the proper decision with regard to the improvement or the progress of antimicrobial stewardship practices. This will help to improve, to guide them what is the most places need to put the resources, not resources financially, from the human resources, from other resources, to help to improve the antibiotic prescribing and stewardship practice. This is the end of the question. Thank you very much. For me, the final takeaway from this presentation and is really antimicrobial stewardship is important. And with evidence-based prescribing and evidence-based use of antimicrobial stewardship, and with this guide framework, which I hope this guide will help as a support tool to all health professionals and the prescriber and workforce to facilitate evidence-based antibiotic use. Antibiotic need to be reserved to the patient who really need it. We have limited resources of antibiotic. There is no more discovery of antibiotic. So we need to ensure that the resources we have from this antibiotic is used effectively for the patient who really need it in severe condition. Thank you very much for this webinar, Vivian. If you would like to add anything.
Well, thank you to you, Dr. Elshenawy, for that excellent presentation and the Q&A, and as well to everyone who's participated. This is a preview to tomorrow, starting the World Antibiotic Awareness Week. So we join hopefully with all you to facilitate activities, in particular for awareness raising, and then what else each one of us can do to follow what is this year's slogan of Act Now. So definitely there's no time to wait. There's so many interventions that can be done, and therefore we need to be the best advocates for addressing antimicrobial resistance. So thank you all. Please do check the South Center website for all the materials, and we look forward to seeing you in a future session. Goodbye, everyone. Have a great day.
Thank you very much.